Going to take me just a minute to pull up my demo patient. So it would be a great time if anyone has questions, either for me or for Dr. Silvers, while I pull up that demo.
Mary, I had a question. One of the things that I saw when I was at a live demo here a few months ago is there's really two different ways to look at this. If you're seeing a patient that day for their chronic medical checkup or their annual wellness visit, and you're assessing all of their high-risk problems, their COPD, their CHF, their kidney failure, then when you get done with your charting, the smart form will still fire that day, but then you're going to have the option to say, nope, I already did this. I did this workflow today, and so then you just move on. And sometimes then we have a person that comes January 12th, and they're there because they're sick. That's an opportunity that the smart form will fire, and I do have a few people that don't come to see me very often, and I think that's the power of the smart form, is to pick up those people at maybe not that chronic visit and make sure that we're picking up on chronic diseases that we may not have been picking up on previously on a yearly basis. So I think there's kind of two ways to look at it. You can use it as an adjunct after your chronic visit to kind of fill in the blanks. Oh, I missed the fact that he had an amputation. I better code that too. Or it can help remind you, oh, this person does have 3 or 4 chronic things that we do need to address sometime this year.
Exactly. I agree 100%. In fact, let me just quickly demonstrate that risk gap that we've been talking about that's in the patient's header is a very quick way for you to see, even if they're there for an acute visit, knee pain, or let's see here, or some kind of acute illness, that if you see there's a risk gap in the patient's header, and I apologize, we're in the test environment, and this is not exactly the way it's going to look in production, in your Epic. The whole thing is not yellow, but the risk gap is highlighted in yellow, just like your allergies are, and some other features on the header. So if you see that there's a number there, just at a quick glance, like Dr. Silver said, you know that patient needs to come back for follow-ups if you don't have time to assess the chronic conditions, or it's not appropriate to do so that day. Just double checking everyone can see the Epic screen?
Yes.
Great, thank you. So before I go back into the chart, I also want to point out at the schedule view, there's the option when we come around for your go live, we will give you the option of adding in a column called RAF due. Remember, RAF is that risk adjustment factor, or you can think of it as a patient's risk score or their gap. We can add in that column, use this properties function here in your schedule view to determine which of your patients on today's schedule you should see a smart form trigger for, and it will give you an indication of what's left to capture. It's not something you have to do, but we found during the pilot that some providers really like to have that there. At a minimum, we'll work with your practice managers to insert that column in your practice manager's view, so we know which patients you'll see them with and make sure that we're providing that one-on-one training for you. Let's see, I'll go back into the patient's chart. So I pointed out this risk gap in the patient's header. You will only see the risk gap if there is a score. The patient has something left to capture. As I said, the number itself is dynamic. So as you see the patient and you capture these diagnoses, it should keep dropping. But on average, just for you to kind of understand the magnitude of a risk gap or a score, 1.0 is considered an average, or that's the average complexity of a Medicare Advantage patient. So something above 1 is considered more complex, and less than 1, less complex. It is a dynamic piece, so you can click on this to see what is contributing to the risk gap. So in this case, there are 4 things that are contributing. You'll also see their ICD-10 code. You don't see the individual risk score for each one, which I think is probably less important, but just to understand what is left to capture for that calendar year. It's visible to everyone on the care team. So it's also great, we invite your staff and practice managers when we do our training to make sure everyone's on the same page. They understand what this initiative is about and know that they will see that risk gap so that you're all working together to make sure these patients have follow-up visits in the calendar year to make sure that any clinical gaps in care are addressed. I also want to mention that this risk gap is now visible across the organization, again, only for those patients in certain payer groups. And once the gap reaches 0, it will disappear from your header altogether. There's not a lot of real estate in your header, and we wanted to be mindful of that. So once you've closed the gap, it disappears until the next calendar year. The SMART form itself is in the plan section. It sits right after best practice, called the Chronic Condition SMART form. You probably noticed this red banner that highlights the top of the SMART form. I'm just going to pull it up to the top by clicking here. I'm going to point out some of the features of the SMART form to you. I mentioned that problem list is a big trigger for the SMART form. COPD for this patient is one of the diagnoses that came from the problem list. So you're seeing the diagnosis section here. You have some documentation selections that give a status, a treatment, and a follow-up for the COPD. And then just beneath that, you can see the conditions from the problem list that would have triggered this section. The other diagnosis sections on this patient's SMART form include CKD stage 4. So this would be one of those that come from lab data. So if the patient has GFRs over at least a period of 90 days that meet criteria for stage 4 or stage 5, they both have HTC values. You will see that diagnosis section. Morbid obesity is one that comes from biometric data. So this patient's BMI is over 40, and that is what caused this particular section to trigger rather than having it in the problem list. And then surgical history will also, some elements from surgical history will trigger SMART forms, such as history of a tracheostomy or an amputation. Both of those have HCC value. Or if your patient is on dialysis, that will also trigger a section, even if it's not on the problem list. I'm going to go back up to morbid obesity and kind of demonstrate how these documentation sections work. So if I discuss morbid obesity and I assessed this today, my patient's stable. I click that radio button corresponding to the documentation that's appropriate. And you might notice that as soon as I did that, it inputted a morbid obesity diagnosis that's based on a BMI range. So this is actually where the billing from the SMART form comes from. This corresponds to an ICD-10 code for a BMI 60 to 69.9. If I wanted to add some additional notes about my treatment or recommendations of this patient's morbid obesity, I can do that here. I can also add notes at the bottom of the SMART form that will let you use your SMART phrases and SMART links. For a section like COPD that came from this diagnosis on the problem list, again, I'm going to say my patient is stable. But you'll notice when I click that radio button, I ended up with a stop sign in that diagnosis field. So there are some sections that require you to input today's specific diagnosis. So if I'm going to enter COPD, it will launch the diagnosis calculator you're all familiar with. I'm going to make my selection. And again, that's the piece that drives the billings from the smart form. For a section like tracheostomy, if your patient did have a history of the tracheostomy but it's no longer in place, and there is a way to say it's not applicable anymore for my patient, and it will suppress that from coming back in the smart form. I'm going to show you how this looks in your note. So we filled out our smart form. We only completed the sections that we assessed today, so we did not assess the CKD. We're just going to leave that. Next time the patient comes in, if the CKD hasn't been captured in the meantime, I'll see it again in my smart form. I'm going to go to Notes. Assuming I've already pulled in my template and worked through that, and I am now at the assessment of plan, there is a smart phrase called risk condition, or COND, that will pull in the documentation from the smart form. You will see that we'd assessed the COPD and we'd assessed the morbid obesity, and I added that little comment that pulls in too. There's nothing about tracheostomy since we said it didn't apply to our patient. We're recommending, strongly that you pull in this documentation into your note, and we can help you add that doc phrase to your typical note templates if you would like. If you don't pull the documentation into your notes so you understand, it is saved with the chart. It becomes part of the encounter report or the encounter summary and sits right underneath the progress note. So it is part of the legal record. I'm going to go back to the smart form. And I am going to deselect just for the purposes of demonstration here. So let's say I'm not utilizing the smart form today. My patient came in for knee pain, and we did not assess any chronic conditions. I want to point out these buttons at the top of the smart form. These are for those situations where you didn't use the smart form either because it was an acute visit, no chronic conditions, which would be to click this button. Smart form was reviewed, it was acknowledged, it just wasn't used. Or the second button is for those cases. Dr. Silvers, I think, mentioned the scenario where your patient came in for COPD, CKD, they came in for an assessment of their chronic conditions, and you took care of the documentation in your note, and you added those conditions to your visit diagnosis, which takes care of the billing for you. So you've already captured them. You do not need to duplicate that work in the smart form. So you can just ignore those sections and be assured that the smart form solution, the chronic condition solution, will catch up. It will get that billing, and it will no longer present those sections to you in the smart form. In that case, you would click on this button to say that the conditions were documented and coded in the encounter. That's what those two buttons are at the top. If you were to overlook the smart form or forget to use it during your encounter, and you go to sign your visit or close the encounter, you will get a hard stop. I'm going to just switch back to my presentation for just a second to show you what that looks like. Just a moment. So just at the top, again, if you're trying to find the visit, had not used the smart form, nor had you used one of those two buttons at the top, it will give you a message that the smart form needs review before you can close the encounter. You can either click here or on go, and it will take you back into the smart form where you can use one of the buttons at the top to acknowledge. So it is a one-click requirement. The next thing I want to demonstrate to you is what happens if you add a new HCC valued diagnosis or a diagnosis with risk score to your patient. So you're diagnosing major depression today. You add it to your visit diagnosis. Oops, okay, single. You will get a best practice advisory telling you that you selected a high-risk chronic condition that's not already on your problem list, suggesting that you add the diagnosis to the problem list for proper HCC billing in the future. So again, as a reminder, it's the problem list that drives that solution, and you need to assess these conditions year after year. So although the visit diagnosis takes care of it today, the problem list will help remind you next year that that problem should be reassessed. You can either then jump to the problem list to add it, or I think the easier way is to either accept or cancel the VPA and just use this quick button here under problem list to add it to the problem list. There's one other feature I'll demonstrate to you, and then we'll open it up for questions. I need to open up a different patient. And we'll go to her smart form. So as I pointed out, there are a number of these diagnosis sections. We have built out about 60 of them to represent the more common chronic conditions in this population. So there are many thousands of other codes that we consider one-offs. You will see them listed at the top of the smart form, but you won't see a diagnosis section complete with documentation options for you because there are just too many of them. They're either uncommon or they're difficult to group. And building out that many sections can really slow down the utility of the smart form. So you may, from time to time, see a single diagnosis listed above with the message that the diagnosis remains to be billed but are not prompted below. Please evaluate and code manually. And in this case, it's a sickle cell diagnosis. So you would capture that as you would in your normal workflow. You'd add it to visit diagnosis. It's on your problem list, so just as you normally would, you push it over to visit diagnosis, and then make sure you're documenting that condition in your note to back up the billing. Any questions? Let's open it up for questions now. Any questions about how the smart form works? Anything you would like me to demonstrate again? Or any questions at all about the initiative or about risk scoring?
I did have one thing I wanted to point out. There was a question last week from the site leads. Wanted it to be clear that currently this is not going to fire when people are working urgent care. They have a different login for urgent care. So folks that working at Merle Hay or Lakeview, South Glen, when they're in urgent care mode, it will not be part of that because that's not considered regular primary care. But of course, if that same person is seeing patients at South Glen as a family medicine doctor or Lakeview, it will fire, correct?
Correct. Thank you for the reminder. And it's also a good time to mention we had said it's going to go live for certain specialties, and those are cardiology, neurology, nephrology, endocrinology, and pulmonology. So those specialties will see a smart form, but it will be a filtered version of the smart form. They'll only see diagnoses that are relevant for their specialty. So you reminded me to say that too, thank you. But yes, reiterate that urgent care, they'll see the risk gap, but they will not see the smart form itself, considering that most issues they're seeing are acute. Any other questions?
Yep. At the meeting a week ago with Dr. Solomon, and Dr. Solomon even acknowledged that it's a hard topic, it wasn't very fun. I'm really hopeful that Innovations is going to be a very powerful tool that won't solve everything as far as being the expert biller and coder and risk scorer person of the universe, but I think it's really going to help us. And in real time, what I saw in a live demo was that family doctor was able to accomplish this in about 30 to 60 seconds per person, and that's once a year, so I don't think that's a huge burden on us to help us really improve this with still having decent workflows and getting about our regular day, which is taking care of patients.
That's right. Thank you for that comment. It is a very efficient solution for presenting these HCC diagnoses. You don't have to put the thought into whether or not you captured them for the year. It presents them to you. And if you utilize the smart form documentation section with one click, you've taken care of supporting documentation for that code for the calendar year. So we're looking forward to the training and support that we'll be giving you in your offices over the next 2 weeks. I believe there is an email going out today just confirming that. You should have all received, or your practice managers would have all received schedules so you know what your go live day is and when you'll be getting that support and that training session. So we're looking forward to that. I will leave the line open for another 5 or 10 minutes in case anybody wants to stay on and has questions. I appreciate everyone's time early on a Monday morning.